Welcome everybody. My name is Sham Sridharan. I'm one of the head and neck faculty members at the University of Pittsburgh, and we are honored to have everybody on this webinar on behalf of my colleague, Dr. Nirav Goyal, who put this together with me, and on behalf of the American Head and Neck Society Population Health and Clinical Research Service. I wanted to present the webinar, Big Data in Academic Medical Research, Uses and Misuses. So we have three excellent panelists with us today that are going to be presenting on how they use big data in their academic research and how to move their respective fields forward. We're going to have questions at the very end where each of the presenters can be asked questions. You can put questions into the chat and I can read off those questions for the presenters. We're going to have a wonderful array of different types of presentations from radiation oncology to otolaryngology to cardiology. So I wanted to kick things off by having Nirav introduce the first presenter.
Great, thanks. We'll introduce each presenter as they start their individual topics. And so it's my pleasure to introduce Dr. Nicholas Zaorsky. He and I worked together for a while when he was a radiation oncologist at Penn State. And now he's moved on and he's one of the radiation oncologists at the University Hospital System at Case Western. He's the vice chair of education in the Department of Radiation Oncology. He has a strong focus on taking care of patients with a variety of cancers, including GU cancers, brain metastases, and skin cancers, and has a specifically research interest in using large data sets such as the NCDB and SEER. He's very active in social media, and if you take a look at some of the stuff that he's posted on X, it's very interesting and very thought-provoking, some of which he'll present today. Thank you.
Hi, team. Can you all see my screen? Okay, perfect. So today I'll talk to you about randomized controlled trials versus real-world data in clinical oncology research. And these are the objectives. And I'll talk to you a little bit about SEER, NCDB, and other databases that we routinely use and sometimes use to replicate randomized controlled trials and why this may not always be a great idea. So as clinicians, our goal is to improve the way that patients experience life. And specifically, the most commonly agreed upon improvements are one of two metrics. We want to improve the quantity of life or quality of life. And these are typically measured by overall survival and patient-reported outcomes, respectively. And there are some potential surrogates that you can see here. And randomized controlled trials are really the studies that we want to do to answer questions that address either quantity or quality of life. Databases like SEER, NCDB, claims databases, et cetera, can measure some of these metrics, but they may not necessarily answer which treatment is better for a particular patient. And I'll show you some of that information in just a minute. So how do real-world data and randomized controlled trials compare, and how do you demonstrate an improvement in the quantity of life or quality of life for an intervention? So ideally, what you want to do is have a comparison of a control group or an unexposed group and an exposed or experimental group. And you use something called comparative effectiveness research, where you're evaluating the efficacy of treatment A versus treatment B. And your goal is to determine the independent causal treatment effect, not an indirect association. So the greatest medical invention of the 1900s, I think, was the randomized controlled trial, because it allows one to assess for this independent treatment effect. And the first randomized controlled trial is often credited as this study from 1948 to evaluate streptomycin for the treatment of TB. Retrospective databases have developed in the past few decades, and they are now termed real-world data, and they have developed concurrently with randomized controlled trials. So randomized controlled trials here, you can see, run since the 1950s and on. Hospital databases have been set up since the 1980s, and now we have national database systems that have existed more or less since about 2000. We sometimes call this big data. And we used to use univariate and multivariate analyses. Now we use something called propensity score matching for national databases. And so this is, again, real world data and how we're using it to compare to randomized controlled trials. Propensity score matching is the most popular modern big data technique to minimize confounding. It's just one of the techniques that is used, but it's the one that probably gets the most press and the one that you will see the most in the oncologic literature. So what is propensity score matching? So let's say you have two patients or two people. Here you've got Prince Charles and Ozzy Osbourne. They're both male, born in the same year, raised in the same area, and they live in the same location, et cetera. And so with propensity score matching, you would say that these two people are the same, and the only difference about them maybe the treatment that they received. And so some would argue that with the use of propensity score matching, we have now recapitulated a randomized controlled trial, and now we can use something like the NCDB or SEER to create a similar study to compare something like surgery versus radiation therapy. And if you look on PubMed for propensity score analyses and head and neck cancer, you'll see just a plethora of these studies, and they're published each year. It's on a variety of topics. And here are just a few of the ones that are published most recently in the head and neck oncologic literature. So unfortunately, there is no concordance between real world data and randomized controlled trials for comparative effectiveness research, and several studies have shown this. So first, I'll show you one study. This is actually from my chairman, Dr. Dan Spratt. He and his colleagues, when he was at the University of Michigan, evaluated randomized controlled trials versus the real world data sets that tried to replicate them and found no concordance. Here's another study that found basically the same exact thing. And when the investigators looked to see if there was one variable that maybe they could improve concordance between the two types of studies, there was none. So if you tried to include age or extent of disease, et cetera, there was really nothing that helped your study and made it match with the randomized controlled trial. So why does this lack of concordance between the two types of studies exist? And the first is that there are known confounders, and these we try to mitigate by methods like propensity score matching. So really, propensity score matching is just one small piece of a larger puzzle. And there are other methods besides this, but there's also something called immortal time bias with its own methods of adjustment. There's something called vibration of effects, and there are also unknown confounders that are just not measured in these databases. So if your goal is to determine the independent causal treatment effect and have no indirect associations, this is ideally what you want to see. Unfortunately, what you have with the retrospective databases is you have a confounding effect. So a confounder is an extraneous variable whose presence affects the variable being studied so that the results do not reflect the actual relationship between the variables in the study. And the example conclusion that you may find is that surgery is associated with improved survival over radiation therapy for something like oropharyngeal cancer. And the caveat is that the patients that are going to surgery are just less likely to have comorbidities, and the folks who are getting radiation therapy, they're getting radiation therapy for a reason that is not coded in the databases. What's immortal time bias? So immortal time bias is when participants in a cohort study cannot experience an outcome during some period of time. Historically, this has been applied to the pharmacological literature, where patients, by the time that they fill their prescription, they by definition cannot have an event. And so we can just substitute a prescription with something like surgery or the receipt of neoadjuvant or adjuvant chemotherapy, radiation therapy, et cetera. And so by definition, patients can't die during this time. The way that you handle immortal time bias can completely change the conclusion in your study. So here's a study that evaluated the use of immortal time bias and how you adjust for immortal time bias for postoperative radiation therapy. And depending on when you did your landmark analysis, you can conclude that postoperative radiation therapy improves survival, worsens survival, or has no effect on it. So how do you identify immortal time bias? Just one quick thing that I look for when I look at Kaplan-Meier curves. If I see no events in the Kaplan-Meier curves within the first few months for a deadly disease, in this case gallbladder cancer, I know that there's immortal time already occurring. What is the vibration of effects? So there's no rule book. So when you do a real world data study and you use your multivariate analysis, there's no rule book on what you need to include in your model. You can include age, gender, et cetera, but really no one says what you need to or don't need to include. And the inclusion of different covariates will result in varied outcomes. This has been termed the vibration of effects by John Ioannidis, who is a biostatistician at Stanford. He's probably the #1 cited researcher of our era. And we can actually use covariate combinations in real-world data sets to generate any conclusion that you want. So our team actually did this study. We looked at over 100,000 patients with metastatic cancer. We evaluated the use of systemic therapy, which is typically the standard of care for many of these patients, versus systemic therapy plus some sort of local therapy. So should you do radiation therapy or surgery for their primary tumor, and does that treatment improve survival? And then in each of the models that we ran over 300,000 models. Each one of these could be an individually published study. So all those studies that you saw in PubMed, that would be included in the study. And we varied the effects. And basically what we found is exactly what we want to show. We can get any conclusion that you want in this analysis. So if you want to show that treatment A is better than treatment B, sure, we can show you that with a low hazard ratio and a low p-value. We can show you the opposite is true, or we can show you that the two treatment paths are identical. So, why do these analyses differ in their findings? Well, if you think of the your outcomes, so this in basic biostatistics, this is usually how we are taught to interpret the outcomes and the variables and the different weights that are associated with an outcome. What you're trying to do in a randomized controlled trial is evaluate just one variable, your treatment and its weight, and you want to separate this from all the other variables. And the great thing about a randomized controlled trial is that you will minimize the effect of the other variables, even if you don't know them, because with randomization, you will control for both known and unknown confounders, and you will minimize the contribution of these noise variables. In contrast, with real-world data, you can try to control for some known confounders, but you probably won't be able to control for all known confounders, and you certainly will not be able to control for unknown confounders. And so the conclusions that you can reach are just different, and you have to associate, and you have to attribute your outcomes to all of those other variables. So when do I think of using real-world data in clinical research? I would think of it for epidemiology. If you're looking at trends, incidence and mortality, et cetera. If you want to look at prognostication, prediction, staging, if you want to evaluate a new staging system like the 8th or the 9th edition of the AHNS, and also if you want to evaluate and characterize outcomes and treatments of rare diseases, the quality of care that patients receive, and maybe if you want to do power calculations for a randomized controlled trial that you later want to perform. But I would not recommend doing these types of studies for comparative effectiveness research where you try to compare treatment A versus treatment B. What are some of the commonly used databases in oncologic research in the US? So the non-claims databases are SEER and the NCDB, and the claims databases are the ones that you see listed here. I'll tell you a little bit about these databases, and then I'll transition to my colleagues who will tell you much more about them. So SEER contains about 1/3 of the US cancer population. The NCDB contains about 70% of the cancer population. And they have some things that they share in common and also some key differences. So SEER is designed for epidemiology, incidence, mortality, evaluating the cause of death, whereas the NCDB is much more of a quality database, and it evaluates the treatment received, the type of surgery that was done, maybe the number of lymph nodes that were removed, et cetera. SEER has been around for a much longer time, since 1972 or 73. In contrast, the NCDB has really been around since about the 2000s. And the NCDB is more of a convenience sample. It's not an epidemiological cohort, whereas SEER is actually meant to represent all of the subpopulations within the US. SEER has the cause of death, the ICD-9 coded cause of death, whereas the NCDB only has overall survival or overall mortality. And SEER also allows investigators to use different types of sessions. So you can do something called a case listing, which is the typical session that we all think about, where each patient is in a row and variables are in columns. And SEER also has a lot of other sessions that you can use to evaluate your the thing that you're trying to study, whereas the NCDB is really just a large case listing file. So they have some common variables, such as tumor information, the TNM stage, cancer sequence number, sites of metastases, when patients were diagnosed, age, race, follow-up time, et cetera. And they have some select treatment data, although the NCDB has much better data about the treatment that was received versus SEER. They also have something called site-specific factors, or SSFs, and these are different for each cancer. So here I'm just showing you a few of the ones that head and neck cancer researchers would be focused on. So specifically for oropharyngeal cancer, you can see something like extracapsular extent, HPV status, and you can use these variables to evaluate a staging system. For example, the 8th edition of the AJCC was actually evaluated with a SEER study, and that was actually a JAMA Oncology publication. Here are some other unique characteristics of SEER. So I would say that some of the key ones with variables are evaluating cause of death from non-cancer causes versus the cancer cause. And then you can also evaluate second malignancy rates, and you can evaluate the rates of death versus the US Census, because it has census data unlike the NCDB. And so SEER is meant to be overrepresented from minority subpopulations within the US. So every few years, a few areas within the US report to SEER. And so here are the areas that report to SEER currently, and they are chosen by the NCI specifically for their demographic distribution and their representation of minorities within the US. The NCDB, in contrast, is sponsored by the ACS. It is from COC accredited facilities. And similar to SEER, it has some lag time, but similar to SEER, it's also free. You can apply to access it. When you access the NCDB, you put in a request, and the ACS will send you a lot of data sets. You can actually merge key files and key variables together. So if you're interested in head and neck cancer, you can actually download oropharyngeal cancer, hypopharynx, et cetera, and you can merge them into a master file if you wanted to. And the NCDB has a lot more treatment information. So I put this in pink text because this is information that is not available in SEER. So if you want to look at the volume that was treated, for example, with radiation, the dose that it received, et cetera, if you wanted to look at days until treatment, all of this is in here. And specifically for surgeons, surgeons are often interested in the type of surgical approach, the number of lymph nodes removed, the margins, et cetera. This would all be in the NCDB. And it would not be necessarily in SEER. NCDB also has information on the length of stay, the 30-day readmission rates, mortality rates in 30 days, et cetera. And they have information about the hospital, so the facility volume, the type of practice that you're in, and a little bit about the comorbidity, but this is just the Charlson score, and it has a lot of limitations. Notably, there's a lot of variables that are not in SEER or NCDB. So I'm listing just some of them here. So comorbidities, symptoms, most labs, imaging, et cetera. I think that these are all key variables. And these are just some of the reasons that the databases, I think start to fall apart if you try to replicate randomized controlled trials with them, because there's no way, if you submitted a randomized controlled trial, and they asked you about basic information about comorbidities, and you said, well, we don't have that, your trial would not be published. And for SEER and NCDB, it's just assumed that you don't have this information. A few quick words on claims databases. So SEER Medicare is probably one of the most common claims databases in the US. MarketScan and Trinetics are some of the ones that are gaining traction. And the way that I look at claims databases versus SEER and NCDB. So with SEER, NCDB, and hospital databases, these are the what I call classical data collection. You really have two time points. You have the time of diagnosis, where you collect information like age, gender, race, et cetera. And then you have your time of follow-up, and then you have vital status, and maybe you have cause of death. And you have no idea what happened before the diagnosis. You have no idea what really happened in between. And with claims databases like SEER Medicare, MarketScan, et cetera, you now have millions of data points potentially, and you have CPT codes, ICD codes, these things called HCPCS codes, and these will code procedures, complications, new diagnoses. They can have text potentially. You might have images of pathology, radiology, and so for these types of database analyses, I think this is where you start to transition from our typical univariate, multivariate analyses to maybe AI and machine learning. And our co-panelists will tell you much more about that in the next section.
All right, Nick, thanks so much for that very insightful talk. I'm sure that's going to generate a lot of questions. For our participants, feel free to post questions to the Q&A section, and that will allow us, me and Sham, to kind of moderate as we prepare for the discussion at the end. We'll move on to our second panelist. So it's my pleasure to introduce Dr. Maribel Sajasevi, who is an otolaryngologist, head and neck surgeon, microvascular surgeon at the University of Vermont, and an associate professor in the Department of Otolaryngology. She's the otolaryngology residency program director, as well as the director of the Endocrine Multidisciplinary Tumor Board. She completed her residency at Duke and her fellowship at the Mayo Clinic, and she's the co-chair of the AHNS Salivary Glands Section Research Committee, as well as being actively involved in other services. And I think some of her presentation today will highlight some of the product that she generated through that service. Thanks, Maribel.
Thank you very much. I'm just going to share my screen. Can we see my slideshow and hear me okay? Great. All right, so I'll be focusing on collaborative multi-institutional database research studies in otolaryngology. And Nicholas gave a really nice overview of the pros and cons of those cancer databases, which will serve as a nice framework for looking at some of the strengths and limitations of these collaborative multi-institutional databases. Just to recap what Nicholas said, when to use real-world data and retrospective cancer databases is if you are looking at epidemiology or studies of rare diseases. Of course, as was noted, there are different pros and cons, and you might select one database over the other based on your research question. So again, SEER are more for epidemiology, incidence, mortality, and cause of death, whereas you might use NCDB for surveillance, treatment, and quality. But as was noted, there's quite a bit of missing data in both SEER and NCDB, notably recurrence data, some other specific tumor features, and treatment complications and toxicity. And so this might be where a good old chart review can be helpful, because you can really get some granular data that enables some in-depth analysis and can help answer certain research questions. So the question is, which one's better, these big databases versus a multi-institutional collaboration? And as I was putting together this talk, actually came across this paper that looked at this very question. So where lies the truth? This was actually a study looking at soft tissue sarcomas. So this is a rare cancer occurring in less than 1% of cancers. And the question that they were looking at was whether radiation therapy reduces local recurrence rates in superficial soft tissue sarcoma. And so they actually looked at this question in a U.S. sarcoma collaborative database. It's a consortium of 7 institutions that compiled a registry of patients. And there were 169 patients that met inclusion criteria for this analysis, and they found that radiation therapy did not improve local recurrence-free survival, disease-specific survival, or overall survival. And this was even after trying to control for selection bias in the patients who received radiation therapy using the multivariable Cox regression and propensity matching score that Nicholas had referred to. And they also were able to find that those who did get neoadjuvant radiation therapy had an increased rate of major complications. So they did the same analysis, but using the NCDB database, they found just a little over 1,500 patients who met inclusion for analysis. But as was mentioned, because there's no recurrence data, they could not comment on local recurrence-free survival, and complications also could not be assessed. They were able to look at overall survival and found that radiation was associated with improved outcomes. And interestingly, though, this actually contradicts all of the randomized controlled trials that had been performed in this space that had failed to show improvement in overall survival with radiation. The authors really felt that overall survival was not an ideal surrogate for disease-specific outcomes in sarcoma. And because of these variables, even despite having bigger numbers, it can limit interpretation and clinical application of results from these larger databases. All right, so what about something more relevant to head and neck? This is kind of our rare disease. It represents only about 5% of newly diagnosed head and neck malignancies. We know it's a heterogeneous group of tumors with 24 histologic types, and there's a wide range of biologic behavior. So it sort of lends itself to a challenging type of cancer to evaluate for these reasons and study treatment to provide recommendations on best practices. I think we can all agree that surgery is the mainstay of treatment, but one important question is whether adjuvant therapy or radiation improves local recurrence-free survival, disease-specific survival, or overall survival. And there really are no randomized controlled trials in this space looking at that question. However, there have been some database studies. So a SEER study evaluated patients with high-grade or locally regionally advanced salivary gland cancers. And in a multivariate analysis, they found improved overall survival associated with adjuvant radiation therapy. In contrast, another SEER study looking at patients with parotid actinic cell carcinoma of all stages found no improvement in overall survival with radiation therapy. There was a study also done with the NCDB, and they included patients with major salivary gland cancer types listed here, and they stratified patients into 3 risk groups. So the high risk group had extranodal extension or positive margins. Intermediate risk group were those that had high T, high N, or high grade histology, lymphovascular invasion, or adenoid cystic. And low risk were patients that basically had none of the above risk factors. And they found that radiation therapy was associated with improved overall survival in the high risk group. However, there was no improved overall survival in the intermediate or low risk group. Some of the limitations were that there could be confounding factors. So in both studies, there were the patients who had higher T and N stage were more likely to receive radiation therapy. And what about unknown variables that are just not being accounted for in the analysis? And then, as noted, because of the data that's not available in the studies, like PNI, which we know is a potential risk factor for recurrence, that cannot be assessed. And similarly, margin status is not in the SEER database, and so is not incorporated into the analysis. NCDB does have margin status as negative or positive, but what about the impact of close margins? And as we noted before, because there's no recurrence data, you cannot assess the impact of radiation therapy on local control. So the studies showed that there wasn't an impact of radiation therapy on overall survival in these lower and intermediate risk groups. But a question that still remains from this is, might these patients benefit from radiation therapy in a local disease control fashion? And so this is where potentially a multi-institutional study could be helpful for studying this question. And so as part of the AHNS salivary section research subcommittee, I helped organize a multi-institutional collaboration. And this was a retrospective cohort study of low and intermediate grade salivary gland cancers. There were 41 institutions that contributed to this patient registry database, and there ended up being 865 patients who were treated from 2010 to 2019 who could be analyzed. And so radiation therapy and margin status were analyzed in regards to local recurrence, and margin status was either negative margins or positive margins, which include microscopic and macroscopic disease. And then further, patients with negative margins were defined as having a close margin if it was less than or equal to 1 millimeter. And we had the ability to collect multiple other variables that we thought might be important in the analysis. So that includes perineural invasion, intraoperative tumor spillage, the extent of surgery, so parotidectomy, or whether a neck dissection was performed, whether a tumor was in contact with the facial nerve, if the facial nerve had to be sacrificed, and facial nerve function outcomes. And so these are some of the results. This was published fairly recently. And so this is one of the figures, and showing that in patients with low to intermediate grade salivary gland cancers, patients with positive margins have improved local control if they are treated with radiation compared to observation. However, if there are negative margins, then there does not appear to be a benefit from radiation therapy. But we always wonder about close margins. So in patients who had margins of 1 millimeter or less, is adjuvant radiation therapy helpful? And our study showed that there was no significant difference in local recurrence-free survival in patients receiving adjuvant radiation therapy or not in this close margin group. And then further, if we restricted analysis to patients who had close margins, but no other known sort of documented risk factors of LVI, PNI, T3 tumor size, or intraoperative tumor spillage, there was no significant difference in the recurrence rates between those who received adjuvant radiation therapy versus those patients who were observed. So it was concluded that in isolation of other risk factors, you could consider observation in patients who solely had close margins as their single risk factor. However, there are limitations as well here. So only 4% in the whole group developed local recurrence, which is great that it's not high, but because of this low number of recurrences, the power to detect clinically meaningful differences may have been low. There's a decent median follow-up of 35 months, and almost 50% having at least 3 years of follow-up. But in these lower grade tumors, they may be more indolent and slow growing, and perhaps recurrences can develop later, and we're just not capturing that. Missing or inconclusive data. So patients who did not have a margin status recorded cannot be part of the analysis. And further, in patients who had negative margins, an actual margin distance wasn't recorded in about a quarter of the patients. So we don't know if those patients had close margins or not, and couldn't incorporate those in that specific analysis. And things like intraoperative tumor spillage, which some folks do feel like could be a risk factor for recurrence, unfortunately is not often specifically commented on in the operative report. And just because it's not commented on, you should not assume that it didn't happen. And so those are not listed as not recorded, and therefore can't weigh into the analysis. And of course, again, being retrospective, what other unknown confounding factors are out there that we just weren't able to account for. So, so which one is better? Going back to that initial sarcoma study that I referenced earlier, I thought they had a really nice conclusion, and it was kind of poetic, so I thought I would share it here. So they say, although the gold standard remains prospective randomized controlled trials, the reality is that these are difficult to organize, fund, accrue, and complete, especially for surgically treated diseases. Is a large registry study a surrogate for an RCT? Probably not. And does a large registry study that only yields overall survival data really provide accurate and clinically relevant oncologic data about the management of a disease? Although we might never reach consensus on the answer to these questions, it is imperative that we recognize that each approach has merit as well as limitations, and that each approach provides valuable information. Each has its place in the literature as we continue to attempt to discover the optimal treatment approach and strive to perform appropriately powered prospective randomized controlled trials. Collaboration and cooperation will be key to moving forward. So I just wanted to finish up with some pearls for anyone looking to potentially lead a multi-institutional collaboration. Most importantly, it's great to start off with a specific research question. And you can hone this using these acronyms and doing a thorough literature review to make sure that this question has not been answered already. And then when you're planning your data acquisition, you want to determine which parameters are to be collected for the study. And I suggest casting a wide net in hopes of potentially capturing, any confounders, and also creating a rich database from which you potentially can do additional studies and look at different questions. It's really helpful to get input from the group. The collaborators are very enthusiastic, engaged, and smart, and will provide recommendations that will really help make your study more robust. And then you'll have to create a data collection tool for abstraction. And it's important that all of the collaborators have this same tool so that the data can be uniform. And I have the most experience with REDCap, and I really like it. I think that it has a very user-friendly format, both in terms of creating the tool to use, as well as just collecting the data. And I've also found it very helpful with the tool that you want to use as many drop-down boxes with specific categories that can be selected, or check boxes, in order to minimize the amount of free text that people have to enter, because that just creates room for error and difficulties with the data analysis. Helpful to create a procedural manual and with instructions for everyone, so that there's clearly noted what the inclusion-exclusion criteria are, and then definitions regarding the variables that are being collected. Definitely suggest testing out the data collection tool with a small group before sending out to the group at large, because there's always some kinks to work out when you actually start testing it on real charts. Don't forget about IRB. Even though this is a retrospective sort of chart review, it still requires an IRB, usually expedited review. And as the host institution, once you've created a protocol that's been approved, it's helpful to share that so that the other institutions can get their IRB running quickly and smoothly. Anything that you can do to facilitate engagement is helpful. And then once you are ready to do data collection, it's really important for good training of the abstractors. I think most people feel that this type of research is a good opportunity for a med student or trainee, which I agree, but they need to be trained on how to do this well, and their performance must be monitored. So kind of reviewing their data collection forms and confirming it's accurate. And as the lead, you might want to hold periodic meetings so that you can resolve any disputes or questions that arise that are coming up with the data collection process. Data must be stored securely, and that's another reason why I really like REDCap. It's HIPAA compliant, And also when you are ready to transfer your data, it can be done securely through the software. Before you do transfer the data though, it's important to have data use agreements in place. Even though most of the data will be de-identified, this is patient data that belongs to your institution, and there needs to be contracts in place that clearly delineate how this data is going to be shared and used. For data analysis, it's really important to review all of the raw data you receive for accuracy, and having a statistician to help with the analysis and interpretation of the results, and ideally having them help from the outset with a design to ensure that there's appropriate methodology. And hopefully all of this will lead ultimately to a manuscript, and it's important to set clear expectations at the outset about authorship. So how many folks from each institution will be able to be on the paper, where this journal is being submitted, and whether this will be presented at any national meetings. And have collaborators review and comment on the final product. And so it is a lot of work, but can certainly be helpful in studying questions and particularly rare diseases. And it's been a really fun way to meet great people and network. And so that's all I have for my part. And thank you for inviting me to be part of this panel.
Thanks so much, Maribel. I wanted to introduce our last speaker. This is Dr. Suresh Mulakutla. I'd like to welcome Dr. Mulakutla. He's an associate.
Thanks, Sham. I think your audio was breaking up. Dr.
Hey,
Suresh, yeah, go ahead.
thanks, everyone, and thanks for inviting me to speak today. I'm enjoyed listening to Nicholas and Maribel, and I'm going to take us on a little bit of a different direction, because the clinical analytics infrastructure that I'll talk about here has been developed actually for the foundation of really some operational and strategic kinds of initiatives, but then has also been the foundation for a number of different kind of academic output and opportunities as well. And so I just want to give a background of what this clinical analytics is. It started about 10 years ago, initially kind of constructed and envisioned by one of my colleagues, Oscar Mariquin. And what it really does is allows us to work at a provider level, at a group department system, and at a system level, to reflect the various practices at each level. And it really tries to leverage the data that we collect on a routine basis during and through the routine care of patients. But it's not simply just the collection of EHR data from Epic, for example. It really is trying to harmonize and integrate multiple sources of data that we all interact with. So not just Epic or Cerner or whichever clinical environment you deal with, but finance data, health plan data, and so on and so forth. And when we look at this, there's a number of challenges. There's obviously the technical challenge of bringing in various data. There's also the cultural aspect of how do you change processes? How do you get people to believe the information that we share? And so we have four different pillars, and you start from bottom up here. One of the pillars is kind of the infrastructure and architecture aspect. How do we move data? How do we identify the right sources of data? How do we move it? And how do we maintain and provide the kind of the operational support? What is the tech stack that's required to maintain this incredible volumes of data, literally terabytes of data? The data management and metadata. So if you look at the this portion, it's really taking the getting the metadata table creations here at this point. Because everything else is all really a series of zeros and ones. Here at the data management and metadata level, we're trying to make it meaningful. Make it meaningful so that we can do the other two pillars, which is those people on the other end of the spectrum, those clinical investigators, those department chairs, and so on and so forth, or those system leaders who want to actually visualize certain aspects of data so that we can identify certain populations or identify efficiencies in terms of how we're taking care of patients, how well or how poorly we're getting patients into our operations. And then, and of course, there's the data science portion of it. So the predictive modeling, how do we prepare the data? Can we use AI or deep learning for these initiatives? And just this visualization just gives you a quick sense of just the complexity of developing this. If you look at the center, that's our clinical data warehouse. And what feeds into it is a bunch of various data sources that we've assembled across the system. We happen to live in a system at UPMC where we have something like 45 hospitals. We have 7 different EHRs, and how do we harmonize all of that together? And that's what this really goes into. And at the bottom, it's once we collect it, how can we visualize it? How can we present it to those key stakeholders? And so we use a number of different data visualization tools to do this. This ultimately leads to our secret sauce on the data management and metadata side. How do we turn that data that we initially ingest into the so-called clinical data warehouse? And how do we put it into the tables that are actually necessary for any investigator to access to answer any question? That question might be an operational one, it might be a strategic one, or it might be a research question about a specific population that may be of interest. And so this is where we have a bunch of data engineers who actually do the programming to transform that data from the previous step into this, so that we can go to this step, which is really defining the work that we do. And I only call it the work, not that the other two other areas are not work, but this is the work that actually people see. This is actually what they visualize. So we work with our partners in our various clinical divisions, and they might say they're interested in certain populations. So how do we define that population? What kinds of outcomes are they interested in? The fun part of the job, I think, is working with all of them across their different various specialties, learning from them how they want to define populations and how do they want to define certain outcomes of measurement. We help them then, with modeling the program for testing various hypotheses. We also have tools for self-service analytics so that people can get into the environment early on so that they can really assess whether the question is even answerable within the context of what we have available. Also, from a tracking perspective or an operational perspective, we give various people access so that they can measure the progress of strategic or operational initiatives that might be embedded within our system. So you see how the whole process allows for a constant learning environment. How do we identify an opportunity, and how can we improve upon that opportunity? That might lead to many publications, or it might just lead to various strategic initiatives that we might do for the health system as a whole. And then I'll show you some stuff on the applied phenotyping and applied machine learning in just a second. We also use this as the foundation for a variety of different ML predictive models. And you can see a list of a few of them that we have. And I've just highlighted the perioperative risk one just because of the audience here. And what we do here is try to use a perioperative risk model that was developed and trained and validated within our own health system. And it predicts the probability of death or major adverse events within 30 days of surgery. And it's based on, you can see 800 some odd features and about 2 million records here. And so we use this actually to give feedback to all our patients who are getting scheduled for surgery, so that the surgeon and the surgical team can decide on how to use that, how that might change the management of that patient. You can see some of the other models here. The serious risk model, for example, the serious illness model, is actually used to identify patients who have serious illness, and if the score is beyond some threshold, it triggers a palliative care consult, for example. So these are actually tools that we can publish on, but they actually also fundamentally affect how we deliver care within the healthcare organization. You can see a list of the other ones, which I won't get into. So on the right-hand side, you see actually we embedded, once we're comfortable with the model, we embed within the EHR these tools so that people can see them. So every patient who gets admitted now to a UPMC facility will have a readmission risk score model calculated for them so that clinicians can decide how to address that, whether that patient needs a sooner follow-up or whatnot. So, we talk about, the challenges of dealing with clinical analytics or analytics as a whole. And we all focus a lot on the prescriptive analytics and the machine learning, predictive analytics, and that's all great. And I think it's all very worthwhile. We should always remember, though, that that's the most mature utilization of it. And I still think we have a lot to do actually in this stage of basically collecting the raw data, cleaning that data, and actually developing ad hoc reports for people to actually interact with the data even before the aspect of prescriptive analytics or predictive analytics. And I'll just show you a couple examples of kind of the left half of this picture, and then maybe end with a little bit on the right. We have a library then of clinical analytics of applications. And on the left-hand side, you see kind of a column of various things. So a library for reflecting our ED work or hospitalizations or imaging or outpatient ambulatory care. I'm just going to show you one of them on the surgical services side. That's one of our biggest applications, just again, because of the audience. And this shows really operational things, strategic things. There's so much focus on how well are we using our operating room time? How well are we getting cases done? This just basically shows data looking at our capability to get volume through, what our prime utilization time is of our rooms, how many average sites are running, how well are we doing or how poorly we're doing on on-time start times and things like that. These things are the things that I think our system leaders, our strategic leaders, our operational leaders are very interested in, and it helps us actually because it helps to help hold people and organizations accountable. And if they don't reach an 80% threshold, for example, on room utilization, that organization or that facility is asked to kind of comment on what the barriers are to get to that. So you can see the utilization of here. This is the kind of report that they might get that looks at our prime time utilization here in the colored bars, and every week now they basically have to report on this. And if you look at on the right hand side, you can see how we have the data to basically reflect why we're not achieving a higher room utilization time, whether it's because of late start times or excessive times between cases and things like that. So this is the kind of a site efficiency or OR efficiency that we set, and this is a report that our facilities get. We want to get everyone to 85%, 80%. If you're not at 80%, you got to report to the group why you're not there. This helps us address how our ASCs and other facilities are how well they're performing, and oftentimes it's because we, the organization, the organization of UPMC might have to provide additional resources to help with this. I chose just a subgroup here of like thyroidectomy. And here what we can see is that kind of the case volume. Again, we can see this overall numbers in terms of how often we're getting these patients into the OR and how well we're doing there. But we now are ingesting finance information. So here's where we see a lot of variability in terms of the supply costs, for example. Here on the top right, you can see the average direct supply cost per case is something like $480. But we know that there's a high degree of variability here. And if you see it on the bar chart just below that, you can see that some folks, and I grayed out their names, but you can see some surgeons are above the 50th percentile, others are below. So can we address the reasons for that? Can we identify what the reasons are for the higher cost in certain cases? And so in the top right, we have some quality measures. And so you can see using this, we use this as an opportunity to interact with our surgeons to see what they're doing. How do they think that they can do anything differently? And I'll tell you just briefly, very frequently, the surgeons, as not unexpectedly, they just don't know the cost of certain supplies that they're using. And so this oftentimes drives up costs because they just use things out of routine habit. And when we make them aware of the cost, then they make these changes. But this is a strategic initiative at an organizational level. And this is a different population, not thyroidectomy, but then we can look at how people are doing relative to certain quality outcomes in the bottom left here, quality outcomes versus supply costs. So what is that relationship? What is the optimal quality that you can get for the optimal cost? We can identify those providers that are in that category, and how can we get more of our surgeons into that area? Sometimes it's a surgeon issue, sometimes it's a facility issue. And so we can start to address those kinds of things. This allows us to basically track any impact of any interventions over time. So we have these charts that basically allow us to look at month to month how we're doing. So if we set an intervention today, I can look at how we're doing cost-wise over time, and make sure that that cost isn't negatively impacting quality for hopefully not, but that's what we want to be able to track. But I just show quickly this one last thing, which is just on a heart failure population. What this data collection allows us to then do is to better phenotype our patients. If you look at the congestive heart failure population, we have, in spite of all the advances we have, we still categorize them in a very simplistic way. Either they have systolic dysfunction, or they have diastolic dysfunction, or preserved heart left ventricular ejection fraction. And I think most of us know that the heart failure population is much more diverse and complicated than that. Well, using our data that I've shown you, we've been able to collect the thousands of heart failure patients and actually better clinically phenotype them into various populations. And ultimately, if we look at the outcome of hospitalized heart failure patients and look at the probability of returning to the hospital or not returning to the hospital, we can actually create 19 different subpopulations within the heart failure population. So no longer is it just two populations, HFrEF or HFpEF. Now it's 19 different populations. And we've actually shown that this is quite predictive, actually. When we look at this, it actually predicts quite well with the likelihood of coming back or not coming back to the hospital. I can go into much more detail on this, but for the sake of time, let's just leave it at that. This is the kind of interesting stuff that we can do at an academic level. And so ultimately what we do is, what this infrastructure allows us to do is to create this continuum clinical care of learning. So we identify some clinical care, we collect that real world data, we then use some analytics to derive that real world evidence, we use some applied machine learning to model it out, and based on those learnings, we can change how we might deliver that care, and then we start the cycle over again. And so that's been a fun exercise that's been productive, actually, operationally, strategically, but also, I think, academically. And thanks very much. I'll just end there.
Thank you so much, Suresh. Sorry for my technical difficulties earlier. I think that was 3 excellent talks. I wanted to leave it to the audience to ask a couple questions. We're a little bit over, and so I'm going to peruse the chat, and Nirav may have some questions as well. But
Yeah.
One question we had from the chat from Dr. Lydiat is, have you seen a change in surgeons' use of resources since this information has been made available?
Yeah,
For
you know
that
what, that's a great question, and the answer is we are just now embarking on a more aggressive approach for this, but the answer is yes, actually. If you look at something just as simple as a surgical blade, there happens to be a surgical blade in our facility that costs like $700 a blade, and no one knew. And so just by revealing that simple information, we've gotten people to stop using it. And because most of them say the blade's a blade from their perspective. Now, it's not to say that this is so easy. There are some folks who are very, very, have a lot of ownership over the equipment they use. And that just becomes a conversation. The key in this has been that it's really surgeon driven. It's not someone like me sending people out data and say, stop using this. It's really a surgeon to surgeon discussion.
You know, I know our talks were about kind of very separate sounding topics, but one thing that seemed like a theme was the idea of confounders. You know, if we take a look at Dr. Zaworski's talk using retrospective big databases where there are potentially more unknown confounders, and then Dr. Sajasevi's where you're now having more heterogeneity and more granular data, and then obviously Dr. Mo Kutla's talk where you have 800 different variables to look at. I guess the question is, how do you manage the unknown confounders in the larger aggregate data where you have less variables, and is there a way to potentially use the data the granular data that we have in the more system level talk to kind of supplement and eliminate some of those confounders? Nick, I don't know if you have any thoughts from your perspective.
Yeah, so I think as Suresh was presenting, I think that this type of data set, this retrospective data set, is one of the perfect uses of real world databases. And essentially what you're doing is it's a triaging system, and it's prognostication, prediction, and if you extrapolate it out to the oncology literature, it's staging and trying to find maybe patients who are at high risk for an event. So I think that using this kind of data to answer that kind of question is perfect. And you can identify some sort of event or some sort of variable of interest that is driving a particular outcome. And so yeah, it's super impressive, Suresh.
Maribel, how did you manage kind of the heterogeneity that you saw in the data that you'd received from different surgeons and different institutions? I know you mentioned, tumor spillage is a good example. You're trying to decipher operative notes to see whether or not they had tumor spillage. Do you have to eliminate that data? And if so, are there better ways to capture that type of information?
Yeah, that's a great question. I think, as I mentioned, sort of one thing was when you create the data collection tool, you really create kind of discrete variables so that everyone can sort of collect the data in a uniform way. But there are factors that are sort of less discrete and require sort of reading an operative report, and a lot of things aren't consistently reported to in terms of outcomes. We were really interested in seeing how surgery, extent of surgery might impact facial nerve outcomes, but those are not necessarily commented on in the clinic follow-up visits. So you can never want to put personal assumptions into the data collection, and so those have to be listed as not reported and excluded from the analysis. So certainly, prospective data collection would allow for sort of more systematic collection of those types of entities. But in some ways, certainly with the multi-institutional collaborations, there's going to be heterogeneity just in terms of pathologic analysis, varied preferences in terms of extent of surgeries. And in some ways that does make the data a little bit more generalizable because you're really getting sort of a real world view. So again, just kind of some pros and cons there.
In that same direction, we have two questions from our audience members that I think are similar. One was, did you have double entry or some way to kind of verify data that was abstracted? And the second was, if you had patients, that were potentially at one hospital in Vermont and then received care at a different hospital, received their radiation at a different hospital, how did you eliminate potentially double entry of the same case?
So let's start with the first question was in terms of every institution was responsible, as I had mentioned in my presentation, of important to train your abstractor, right? So you sit as if you're mentoring somebody and you want to sit down with them and go over the manual that has hopefully been created that gives all the important instructions on the data variables that you're collecting. And we've instructed folks to just make sure to kind of at least, for 10% of the charts, try to do a confirmatory chart review to ensure that data abstraction is accurate. As far as the second question is concerned, I can't speak necessarily for other institutions because varying places have their own way of obtaining the appropriate patients to be evaluated. So some folks obtain their patient cohort through their cancer registries, whereas other folks, including myself, use Epic, Slicer Dicer as a way to get the patient cohort of interest. And so in that sense, at least for me, all of the patients had to have had their surgical treatment at the University of Vermont. And so we're following that patient through because that is their entry point, is they had to have had surgical resection at our institution. And so then you follow them longitudinally, what was their pathology result? Did they have adjuvant radiation therapy? And even if they had it elsewhere, that wouldn't be a duplicate entry. That would just be that patient with the data collected sort of on their path of treatment and follow-up.
Great. I think that's a great point. If everyone is entering into the study at the same point, then it should eliminate the possibility of them being duplicated, even if they went to a different institution. There was one other question in the chat, and I think we may have to end it there just based on time, from Dr. Joe Curry, which was looking at whether or not any of these databases can be combined. Is there a way to combine a pharmaceutical registry with health databases? And maybe that's something that Suresh can answer, maybe that's something that Nick can answer. Whether or not we're able to get more and higher quality real world data.
I can start, and then maybe Nick can chime in as well. I think the answer to that is yes, and that's what we've been trying to do. In fact, what we have done in our system is combine this with pharmacy data, some health plan data, but also even public databases. For example, area deprivation index, so publicly available data that we can ingest and look into it. Now, of course, that's not at a patient level; it's at a zip code level. But we've tried to incorporate a lot of that. There's another opportunity, I think, with in Pennsylvania with this what's called so-called PHC4, SG2, and something. I think various states have similar things that basically highlight or have publicly available data for the state about their inpatient and outpatient flow. And so we've used that from a strategic standpoint about where our patients are coming from and whatnot. But the concept is exactly that, of trying to incorporate different data sources to augment what we collect already.
From an oncologic perspective, for U.S. cancer databases, there's currently no way to link something like SEER and NCDB, and you don't necessarily know which patients are which, and there is some overlap, and you actually don't know which patients are the overlapping ones. There's probably going to be more of a way to create these, larger super databases with the insurance claims databases, because they have so much more information. They have more of the patient identifying information. And I'm actually waiting for, larger companies like Facebook or, whatever it might be, to just start to aggregate patient information, because I think a lot of patients will actually, gladly share their patient records online. Like if we can get something like Epic if patients will agree for their information to be shared in a large database, and maybe for that data to then be easily transferred to other institutions, or a large database that will combine it for larger questions. I think patients would actually agree to that, as long as they have some reassurance of their data being still anonymous. So I don't know when that day will come, but I think someday we will see that.
All right. Well, thanks again to all of our panelists. I see that we're about 10 or 11 minutes over. And thank you to all our participants for staying on a little bit longer. Everyone have a good evening. Thanks again.